Early myelofibrosis is a big topic. One distinction I'd like to make is that people sometimes confuse this with pre-fibrotic primary myelofibrosis, but that is a specific pathologic entity. It has its own pathologic definition. So early could be pre-fibrotic, yes, but it could also be overt, but just clinically early. So in this setting, patients are, of course, at a better stage of their disease. They have less cytopenias, they have less additional mutations, spleen may not be as enlarged. And so certainly some of them can be observed, but then also there's a lot of interest, for example, in interferon, because we know that interferons may be able to disease modify. And if you go in early and intervene with interferon, you have a better chance of being able to sort of retard the progression of the disease. And then there's also ruxolitinib. We've learned more and more that the earlier you start ruxolitinib in the course of a patient's disease, the better the outcomes, both in terms of efficacy and safety. We learned that, for example, from one of the COMFORT analysis, which showed that if you started before 12 months from diagnosis, patients do a lot better, even in terms of survival, than if it is after 12 months. Now, of course, COMFORT trials enrolled a different population. I would not call that early myelofibrosis, but extrapolating from that and other data in earlier risk disease, such as from the JUMP trial, ROBUST trial, things like that, I think ruxolitinib definitely has a role in patients with symptomatic early myelofibrosis, splenomegaly, and those sorts of situations.